Welcome to the Wednesday afternoon lecture series. My name is Andrea Naranjo Erazo, and I'm from the Office of Intramural Training and Education. I am a co-director of the NIH Academy on Health Disparities, and I am thrilled to introduce today's WALS speaker, Dr. Guadalupe Ayala, whose evidence-based health interventions have been successfully translated into real-world use. Dr. Ayala is Professor of Public Health in the Division of Health Promotion at San Diego State University School of Public Health. Among other things, she's the director of the Institute of Behavioral and Community Health. She has served as principal investigator on more than 20 grants, cooperative agreements, and endowments, totaling tens of millions of dollars from sources such as the NIH, the CDC, the Robert Wood Johnson Foundation. Dr. Ayala is known best not for preaching from an ivory tower, but rather entering the community she serves with a theory-based yet hands-on approach in reducing health disparities in obesity, diabetes, and asthma by improving diet, physical activity, and management of chronic conditions. She works closely with lower-income Latino and LGBTQ communities. Among her many successful intervention projects is the CDC-funded Familias Sanas and Activas study. For this project, volunteer women were trained to be physical activity community health workers, also known as promotoras, to offer free exercise classes to the public. Similarly, her Puentes hacia una mejor vida studies evaluate a diabetes peer support program to help adult Mexicans and Mexican Americans navigate the healthcare system, handle situations in their communities, and interact successfully at home, all with an eye toward managing and controlling their diabetes. Such programs have resulted in significant improvements in health behaviors and health status, such as healthier eating, more exercise, and reduction of waist circumference, high blood pressure, and depression. Dr. Ayala received her undergraduate degree in cognitive psychology from University of San Diego, her first master's degree in experimental psychology from California State University in San Marcos, and a master's of public health degree, followed by a Ph.D. in clinical psychology from San Diego State University in 2002. Dr. Ayala next accepted a position as assistant professor at the University of North Carolina, Chapel Hill School of Public Health, before moving back west in 2005 to co-direct the CDC-funded San Diego Prevention Research Center as an assistant professor at San Diego State University. Lastly, I would like to add that Dr. Ayala has been honored with numerous research, training, and service awards. These include the Henry Montes Presidential Award from American Public Health Association, the One Family Excellence Outstanding Faculty Research Award from California State University, and the San Professor of Creativity and Innovation Award for Teaching. Dr. Ayala, thank you so much for being with us today. And on behalf of the NIH Academy on Health Disparities and the entire NIH staff, I welcome you to the NIH.
Thank you so much, Andrea, and that was a beautiful introduction. I appreciate it very much. Thank you, everybody, for joining me, and for those who were involved in the invitation, for inviting me to share some of the work we are doing related to minority health and health disparities here in Southern California. The efforts I will be describing today are actually going to be focused in a rural community to add that context into the complexities of what we study. As Andrea mentioned, my full name is Guadalupe Ayala, but I go by Suchi, so any questions, feel free to address me as such. The efforts I'm going to describe today would not be possible by the many organizations that are behind us to support all of this effort, including originally the Institute for Behavioral and Community Health, founded by, among others, Dr. John Elder, And then most recently, the SDSU HealthLink Center, both the endowment, our center, and now our new clinical research network, all funded by the National Institutes of Minority Health and Health Disparities. So I'm very grateful to them for seeing something in us to invest to address the issues of health disparities. During this for you might be a little different than what you have seen before, but it's essentially a journey, a research collaboration between an academic institution and a federally qualified health center. In the process of describing this journey, I'm going to talk to you about how we established a research partnership, how we then went about designing a series and then evaluating a series of intervention studies within the community, and then what evidence we were able to build for preventing and controlling childhood obesity in Imperial County, which is a significant issue. What I hope you'll get from this lecture is really an understanding, and I think maybe I'm speaking to the choir here, that research is really an evolution, but I think that this is an important thing to keep in mind because we often get stuck in a path and not realize that the path may go down a different road than what you would have anticipated. The second thing to remember is that influential factors that may promote or inhibit the development of a program of research, really learning to identify those in that process and what you need to do and how to be strategic to harness those lessons along the way. And also really to recognize and acknowledge the boundaries of your own expertise and where you need to seek the expertise of others. And this includes individuals within the communities that you're working with. So you'll see, you'll hear me use the word we a lot. I do not work alone. And the effort that I'm describing today, this evolution, there is another individual who was highly involved in this process. So just to describe myself and then my collaborators. So I am a daughter of immigrants. My mother is from Argentina, my dad's from Mexico. I was raised in Imperial County where this work occurred. So I was intimately aware of the community as a child, left the community to seek higher education, and then went back to try and apply some of what I'd learned to address the health disparities in this community. I had the privilege of studying, obtaining a couple degrees, social psychology, clinical psychology, and public health. And I've been an academic researcher at San Diego State since 2005. The primary collaborator in this evolution of research is Leticia Ibarra. She is also the daughter of immigrants and raised in Imperial County, although we did not know each other as children. She is much younger than myself. She studied community health, so she was identified from Harvard using a probably standardized test, plucked out of Imperial County, brought to Harvard to study, and then went on to pursue her master's degree at University of California, Los Angeles, and then went back to the community again with the same philosophy as I to try and use our knowledge to improve the health of the community. She was formerly, at the time we were working together, director of the programs at this federally qualified health center, and now she's working at the Indian Health Council. So our organizations, very briefly, that were involved, so the primary ones are the Institute for Behavioral and Community Health, and then the federally qualified health center, Clínicas de Salud del Pueblo. We had some, as I mentioned earlier, some very overlapping mission in terms of what we were seeking to do, but obviously bringing very different expertise on our side, more of the science and design, statistics and whatnot, and then really on the FQHC side, really understanding the community, the clinical needs, but also some of the research given the individuals involved. The community we worked with experiences a lot of social determinants in Imperial County. It's actually often highlighted, if you may have even seen them in the New York Times, probably in the last year, unemployment rates, health disparity rates, and whatnot. So on the right-hand side, you'll just see geographically where we are located in the US. So we are on the southwesternmost corner, right on the US-Mexico border. And just in comparing some of the statistics, the poverty rates, as an example, at the time these statistics were drawn, in the US was about 14%. In Imperial County, it was about 24%. Language access is a huge issue in Imperial County, where Spanish is often the dominant language. About 35% reporting access issues in terms of the English language. But what I think these statistics fail to communicate is really the strong desire by many community partners and the sort of the social capital that one often sees in rural communities to try and address some of the big problems that residents face. So recognizing and knowing and understanding this community, as a resident of the community for many years, and my family was very social justice minded oriented, so we were often marching alongside Cesar Chavez and others in the farm worker movement. And coming back and obtaining a faculty position at San Diego State, I immediately reached out to the director of the FQHC of Clínicas and asked if they would be interested in partnering with me on research. And Ms. Bell, the CEO, was very interested. And so we submitted an application to the American Cancer Society to implement an intervention, essentially to try and start to address the problem of obesity, but through changes in diet. I felt that was a good place to start, since physical activity was just going to be a much harder behavior to try and change in the community. What I didn't mention earlier is that this is a rural community. It is on the southern end of the agricultural belt. It is very hot, probably anywhere from 6 to 9 months out of the year. It could be 90 to 110 degrees. So anyway, turning back to funding, we received funding from the American Cancer Society, and we were set to start implementing. And so Ms. Bell referred me to the individual that I would be working with in this context. And that's when I started learning my lessons. So Macy Barra, she was the director of programs, but also really responsible for a lot of the outreach that was occurring as part of their efforts to try and reach many of the underserved that even in the efforts that they were hard to reach. So the first thing she said when she was, this won't work. The intervention model doesn't fit the community. Families will not welcome this type of involvement. The content is too technical for families. The strategies are not sustainable. So why should we even do these if this isn't something that we're able to sustain? So thankfully, maybe through my upbringing, my mentorship, and any other lessons, I knew immediately that I found the right person to work with, because she brought the expertise I needed to the table to make sure that my research was really relevant to that context. And that's really began what became more than a 10-year journey in how to do community engaged research, in this case, specifically with the Federally Qualified Health Center. To start this journey, to describe this journey in the context of 3 studies. We had more studies that were funded. These are 3 good examples of the evolution in that partnership. I am using 3 studies that were funded to describe the evolution on 2 dimensions important to address specifically childhood obesity, a model that we eventually to childhood asthma and found that it was equally effective. This occurred through 3 sources of funding, originally through the American Cancer Society Healthy Eating Intervention, and then an intervention funded by Peers for Progress that was on diabetes control, and then the CDC-funded California CORD study, if you're familiar with the CORD interventions, that were trying multi-level interventions to address childhood obesity. Key elements, as I mentioned, were the concept of peer support and organizational design. So when I refer to peer support, in this case, I'm referring both to who's involved and the type of support they're providing. In these efforts, peer supporters have most commonly been referred to as promotores or community health workers. And they can provide a variety of types of support and in many, many different contexts, as you can see here. By organizational design, I mean that that we have used for program planning models include, as an example, the chronic care model. And that was really to inform ways in which the clinical system can change the delivery of care and how, for example, electronic health record systems can be used to ensure adherence to treatment guidelines. So I'll first start by describing how we worked with clínicas when they were using only paper records. This is the first of the 3 studies, and it's referred to as Entre Familia, again funded by the American Cancer Society. And this was designed as an outreach program conducted in the form of home visits. The focus on Entre Familia was on promoting healthy eating through family-based home visits and telephone calls conducted by trained promotoras. So the visits were designed to occur over a 4-month period and were facilitated by edutainment, DVDs, and a family manual. Important to this the evolution of the model I described is that this was really an outreach-based effort. There was no attempt at changing clinical care. So what we were trying to do is design a study that was potentially sustainable just by being delivered by community health workers that were hired through the organization and supported them. So we actually modified significantly the design after Leticia came on board to really help make sure that the intervention at that point fit the context. And I'm forever grateful the American Cancer Society was willing to work with us to revise many aspects even of the budget to ensure we met the needs of the organization. From a study design perspective, this was a randomized control trial. So we identified families that were eligible, randomized them to either the intervention or a control condition. And then they worked with individual promotoras, and then we followed up with them at 4 months and then again at 10 months. The home visits essentially are very typical of any kind of programming, whether it's for treatment or control, setting some very specific goals from each session, reviewing those goals and objectives at each new session. One of the innovations we had with this study was the opportunities to actually develop some materials that were a little bit different than had been developed before, and using some of the concepts regarding edutainment to try and engage all family members in the change process. So we know that decisions regarding what people consume are not only made by the mom, which is often the assumption, but the individual who controls the purse string, who often makes decisions in the stores, our fathers, our grandmothers and grandfathers, and so we wanted to make sure of that. We started each session with that to try and engage as many family members as possible, have a topic, the theme, and then really go through some skill building with them to hone in on some of the behavioral skills that one needs for health behavior change. The findings, there's lots published on this study. We had fantastic fidelity to treatment. So the promotoras, we estimated a dose of about 11 visits, each of about an hour, and we had 11 visits delivered. So fantastic fidelity also to the content. The changes were modest, which is not uncommon in our types of research when we have to rely on self-report measures of diet, which we know are limitations. But we did see self-reported increases in fruit and vegetables among the moms, less fat consumption. We had children reporting less fast food consumption, more variety of vegetables. And then among a subset of fathers, because we were really trying to understand the change process in the whole family, we observed reductions in soda consumption and snack consumption. And what we eventually found through focus groups is that those last two indicators, the findings on fathers and children, was the fact that they were less likely to go to a fast food restaurant between school and sports practice. So there was a clear behavior change and a contextual change that happened within a dyad within that family. We also saw a lot of reported changes in mom's behaviors. So saw some really nice findings, both in terms of ability to implement and potentially sustain the intervention in the organization, given how it was implemented with such great fidelity. But we knew something was missing. There was no outreach to the community, into the clinic, really to capitalize on clinical care and bridge systems. So we felt that in order to really create even stronger, more potentially lasting changes in the family, we needed to capitalize on the fact that the organization was a healthcare agency and providing really critical care to these families. We know that healthcare providers are trusted voices and sources in the Mexican origin community, at least in this community. And so we needed to figure out what model helped bridge that. Thankfully, this led to the second study. So this led to the conceptualization and eventual funding of the Bridges to the Better Life study, or what we refer to as Puentes hacia una mejor vida. This was in response to a call for global efforts in diabetes control that were using a peer support model. Obviously, given the connections between obesity and diabetes, we felt that this was a good fit because we didn't want to start deviating also too much, but also the opportunities to see maybe what other countries were doing, because we knew that they were going to fund some underdeveloped countries, and we thought, given the rural context, maybe we'd learn a little bit more about the application of our model. So in this case, we were also very interested in trying to integrate more of the delivery of care. So how is it that we can both develop a sustainable model through maybe potentially volunteer peer supporters, but integrating them more into the organization and into the treatment of care? So in the Puentes study, peer leaders or líderes were trained to provide support for diabetes self-management, including behaviors that are enacted at home, like monitoring what's eating, or that could also happen in the community, in the restaurants, or maybe how to speak more effectively with one's healthcare provider. This could happen in groups, this could happen in home visits, so we were really open in terms of the delivery mechanism or the implementation strategy that they chose to use, and train them on all different types of strategies. Important to the evolution of the model, the peer support, again, the whole idea was to try and bridge into clinical care mechanism, or that bridge into clinical care to serve as a mechanism of support. We were also very interested in trying to bridge the connections between the peer supporters and the clinical system. Here's a good depiction of that. So they tried to work, if you're familiar with the social ecologic framework, which I tried to depict here in terms of various levels of influence on one's health behavior. You can see here that the individual and interpersonal level, really trying to teach the patients and the caregivers how to provide better support, how to create a home environment that's more supportive of diabetes management, in the community and in the healthcare system environment, how to get better information from one's healthcare provider, how to maximize what you're getting out of that visit, how to maybe better understand what is being prescribed to me and for what purpose. And then really also that community navigation, and that being really critical in a rural environment where folks don't have a lot of access to transportation. So how is it that I can maximize what I get when I am able to get into town? I hope you can see this. On the would be left-hand side, you'll see that we had moderate fidelity to intervention plan dose. So essentially, we were trying to plan for about 8 contacts. So unlike the Entre Familia study, we only achieved about half of those contacts. Surprisingly, but not so surprisingly at the end, most of those contacts occurred by phone. We thought that given the age of the population, this was a slightly older population, that they would prefer more in-person visits, but there was actually more preference for telephone visits. And so that was an interesting thing that we observed. The figure shows you that we did see decreases in A1C levels. So this was a high-risk population, one whose diabetes was not under control, and so we were able to reduce that at least to somewhat clinically meaningful levels. But something was still missing. The peer leaders were not having enough in-reach into the clinical system. They were still perceived as sort of external to the clinical care team. We really needed a model, and this was, again, based on discussions with myself, all the team members, the promotoras, the leaders, that we needed better integration across multiple systems. The potential for diffusion of responsibility is too high when one only works with one system. Messages, we learned, needed to be universal. And this led us to the conceptualization of the California Cord study, funded by the Centers for Disease Control and Prevention, in which we tested a fully integrated model of peer support within the clinical healthcare system, but overlapped that with a public health intervention that occurred in multiple sectors. The clinical intervention involved an adaptation of the chronic care model for obesity that we used to essentially identify evidence-based, multi-level, multi-sector approaches to change policies, systems, and environments in as many environments in which children eat, learn, and play in this community. And so on the outward side of the circle, you'll see that we worked for the public health intervention. We worked in many different sectors, elementary schools, early care and education sectors, restaurants, and recreation centers. And again, in all of those contexts, trying to change not only the intervention agents' behaviors, but also the policy systems, environments in which those behaviors were being enacted. We also did that, so looking on the left-hand side of the figure, we also did that within the healthcare system. And really with the concept that a child in this environment cannot maintain a healthy weight without having a healthy environment to live in. The weight-related behaviors that we focused on, that was around the concept of our choice. So we thought, start where you're ready to start. We're specific to healthy eating, physical activity, healthy beverage consumption, and healthy sleep. Healthy beverage was added separately. There was a lot of evidence of even soda and Gatorade being in children's baby bottles. The size of beverages that would be served in restaurants were just huge. And sweet tea became a very common phenomena to be served in restaurants instead of water without request. So we've identified those with community members and through formative research to identify what to target. Importantly, related to behavior change is that we also consider within each factor both what we call the acceleration and deceleration targets. So what are the things that we need to increase and what are the things we need to decrease? And that's sort of based on behavior change principles regarding substitutions are often more easier to make than elimination or complete overhaul. The healthcare system changes were huge. So there was not only the integration of a new electronic health system into the organization. So around the time that we were finishing the Puente study, they went into fully EHR mode. And so in a way, it was also good because the healthcare system learned how to make modifications that were specific to this intervention while at the same time learning the system itself. So the policy system and environment changes within the healthcare intervention involve modifying the delivery of care for the prevention and control of childhood obesity. This started by drafting and adopting internal policies. So that's one of the things we learned very quickly is that in order to adhere to standards regarding meaningful use of electronic health records, once policies are adopted about how to use it, then there's more obviously greater enforcement or abilities to enforce that. A lot of changes in the EHR system to change the flow of a well child visit to promote adherence to guidelines, help the providers and the families set some goals, and helping to create that feedback loop. And then we provided both healthcare providers and staff within the clinics training on how to implement all these practice changes, as well as referring the families to an evidence-based family wellness program. The family wellness program was actually an adaptation of a combination of what we learned from Entre Familia and what we learned from a childhood obesity study funded by NHLBI a few years prior, Aventuras para Niños. And so the idea is having the opportunities for families to work with paid promotoras, community health workers is really important complement to a policy system and environment change. And it's not so much about knowledge, but it's actually about skill enactment in an environment or context that doesn't have a lot of resources. And so within this program that they delivered over a one-year period, targeting those 4 behaviors and the ways in which to engage them at the same time as providing them all types of different social support. The public health intervention occurred in 4 different settings in 2 different communities. So we worked with most center and some private family-based childcare providers. We worked with all elementary schools in the communities, with all community recreation, and with a handful of restaurants. And we were very mindful of restaurants. So the only reason why we ended up doing 3 pilots is we realized that there was a lot more work that we needed to do. And I'm grateful for NICHD for funding some additional pilot work after this work started to help us better understand how to work with this industry. So we did a pilot with 3 restaurants that are strategically located right across the street from the elementary schools. So the perfect individuals to engage in this process. Here's an example of some of the strategies we used with each of the sectors. So often the methods were really to work with them to do their own environmental assessment, develop action plans and goals with them, then develop capacity building and training, provide ongoing technical assistance. For the early care and education centers, and very similar to the schools, there was evidence-based SPARK curriculum to promote physical activity, BMI assessments to provide the feedback loop to the schools to let them know how they're doing. Resources in this low resource environment are really critical. Working with very specific environmental agents was critical, not only and making that connection with those of us from the academic side, and then making sure that we had the expertise that they needed at the table. Here's just some pictures of some of the changes, so really getting the teachers involved. There are no PE teachers in these elementary schools, so they are expected to do all of the PE themselves, and that can be challenging for some of them. So really giving that capacity. They chose community gardens. It was a surprise to us. We thought in a rural environment, they might not want it, but it's actually very much a part of their culture. And then here are just some examples of some of the restaurant work we did. And really the whole idea was to try and promote small options. So what we actually did a very extensive observational study of all the restaurants, enumerated all of them, went into the restaurants and coded information and found, I think, of all the independent restaurants, there was only one that had a child menu. So there was even an option of a child menu. And so portion distortion obviously being a huge issue for this community. We evaluated the California Cord study on a quasi-experimental design. So there were 4 conditions, essentially. The top left condition being the healthcare and the public health intervention. So essentially you had everything going on. Just going to your right, if I have that correct, you have the public health intervention only. And then if you go down, you have the healthcare intervention, and then we have a control community where we were able to get assessments from families, but not explicitly intervene in those communities. Here you can see some of the demographics of the overall baseline sample of children. So we had 1,186 children in the evaluation cohort. There was average age of about 6 years old. Most of them were Latino Hispanic, and about half were male, half were female. Those in the healthcare condition were more likely to be foreign-born, and that was an unusual finding. There was no reason we would have expected that. We had pretty good cohort retention at the 12-month, and it dropped a little bit at the 18-month. Findings were modest. What I'm sharing right now are the findings from the 12-month. Most of the changes in BMI percentile, and we know the issues with that as an outcome, but it is something that the Cord study had agreed on. This was a multi-site intervention. But we did see a trend to indicate larger differences, so better improvements in the healthcare component compared to the others. And this was also the case with the child caregiver reported psychosocial quality of life. So improvements overall, trend in improvements in quality of life. Similar pattern with physical activity quality of life. And then in terms of diet, which we're still trying to figure this one out. So we use the block food screener. This is, it's been validated, but again, we know that there are limitations with any sort of self-reported diet. We did find that the healthcare intervention delivered in one of the communities that was not part of the public health, so this was just healthcare, resulted in significant drops in daily calories. Not entirely sure why. And yeah, so this is something we're still trying to explore. What I've tried to describe today, and I hope we have enough time for questions, is really the evolution in this partnership that went from what was primarily outwardly facing attempt to try and address health disparities with the involvement of peer supporters to one that became an entire system change to integrate both inward and outreach approaches to address obesity, diabetes, and related conditions. We, as a final note related to the model, we have since tested it in the context of childhood asthma funded by PCORI, and that actually resulted in significant improvements in child's quality of life and reductions in frequency of ER visits. So as I close this lecture, I just want to circle back by starting and saying that I hope that I have described how we established this research partnership, how we went about designing and evaluating several trials, and really how we learned a lot along the way what worked realistically to achieve the impactful changes that we saw in 2 very important chronic health conditions. As it relates to your research or anything that you might be doing, really understanding that research is an evolution. And I know most of us think about that, but we don't stop and think about that enough. And I think that that would help us in terms of how we're thinking about our science. Keeping notes, seeking advice, listening carefully, and learning from your mistakes and successes, I think is also critical to advanced science. If I had been rigid in my approach and thinking that this way to need to do, I never would have gotten where I am. And finally, recognizing your limitations and acknowledging them, but also recognizing the assets and interests of others, including, most importantly, your community partners, clinical partners. They really know what's happening in practice, and we need to bring that knowledge together better. Thank you to all my collaborators. Could not have done this without you. And thank you all for listening.
Thank you so much, Suchi, for that amazing presentation. And just a reminder to put your questions. You can click the button that says send live feedback, which is below the video cast window. And that way we can receive your questions. We do have some to get us started. Let's see, the first one is, oh, well, I'm intrigued by your comment about changing the flow of well child visit. Could you expand on that?
Yes, absolutely. When we were designing the chronic care model for obesity for the California Cord study, ultimately what we wanted providers to do was to refer, where we started was to refer families to a family wellness program, because we knew that that model from both childhood obesity prevention research and childhood obesity treatment research, that type of model would be instrumental. And so we thought, okay, let's make sure that they get the referral. And so we started to make clinical system design changes to introduce the referral, right, into the healthcare provider visit. But what you find is that when you start to make clinical system changes in one area, they start to have a domino effect. And so what we realized, we thought we need to change the system from right when they walk in. Right? So if a family's coming in for a well child visit, there is a system such that there will be completion of obesity care guidelines care by the end of that visit if the child is, if the child's weight, usually the height and weight indicate that they're at risk or that they already have obesity. Does that make sense? So the fact that they can't necessarily, you can't change one aspect of the system without thinking it from the very beginning.
Yes, thank you. And before we go to the next question, I wanted to repeat the CME code is 44443. And the next question is, it's about if you have seen difference between the immigration status and the health behaviors, like whether you just moved to the US or you've been in the US for a while.
That's a great question and a very complex question. There are, if you're just looking at immigration status, so let's, and maybe I'm inferring from that maybe you're referring to generation status, whether someone is born in the US or not, or whether they're born in the US of immigrant parents, of US born parents. So we classify people as either first generation, second generation, third generation, and fourth generation. I, as a daughter of immigrants, would be considered second generation because I would be born in the US. So that's one way of looking at the influence of immigration status and health behaviors. And when looking at it from that perspective, we do find in general that those who have been born in the US or are of later generations tend to engage in less healthy, for example, dietary behaviors, physical activity behaviors. But that is also partly moderated by the extent to which they have integrated into the US culture. And so when we think about immigration status, it's not just where we have been born or where our parents have been born, but the extent to which we ascribe to certain cultural beliefs, knowledge, who we socialize with, who influences what we consume, what we think about, what risk behaviors we may or may not engage in, what health behaviors. And so that's another layer on this, and that we often refer to that more like acculturation research. So there's often more variation in there. Now, with the acculturation research, is that related to health behaviors? Yes, absolutely, independent of immigration status. So the idea often is that someone who may be more assimilated to the US, adopted more of the US, whatever that might mean in their context, tend to engage in less healthy behaviors across a number of behaviors. There's the hypothesis that maybe it's stress related, so the stress of acculturation, adaptation process. There are many other theories, but that's just one of them. I hope that answers your question. It is a very complex question, though. It's a good one.
Thank you. The next question says, like, you mentioned the changes from your initial effort design to the end product that actually ended up being implemented. What do you think is the most important lesson you learned through the work about how to effectively work within this community?
I would say specifically this community, but I would say generalized to other communities that in which we see such disadvantage, and this again is a rural community. Humbleness, because they suffer so much, and yet they still strive for excellence and integrity in what they do. Like they're still like, even with COVID, it's like, but we need that evidence base. Like, you know, there were few organizations that had to stop their research, absolutely. But many of the clinical organizations, partners that we work with, federally qualified health centers, hospitals and whatnot, they were like, we can't stop. The disparities are here and they're only going to get worse. And so the lesson I've learned is to be humble to them in their efforts to do this, and how is it that I can help them in that process. So it's maybe more listening to them to figure out what they need, I think. And yeah, what I don't know how I've learned, and I'm just grateful I have, is how to then communicate that to a funder. If I could figure that out, I would appreciate that.
Thank you. Another question is regarding the community health workers. What were the criteria for selecting the community health workers? Did they collect and report information about their visit interaction?
Yeah, great question. The community health work, so in the 3 studies, I use the term peer supporter intentionally as a broad term, because in each of the 3 studies I mentioned, they actually were referred to differently. So in the Entre Familia study, they were referred to as promotoras. It was only females, individuals who were from the community, who spoke Spanish. This was a predominantly Spanish speaking, who themselves had families, who had an interest in promoting healthy eating. They were paid by the healthcare organization because they were part of their outreach department. Some of them were already paid employees. We brought on some new members. We had to screen out some individuals who have really strong beliefs around food, and that could interfere with some of the messages, you know, around herbal medicines and that kind of stuff. So we had to be a little bit careful with that. That was the only, I think, criteria that we had to worry about. In the second study, this was a volunteer-based model. We did not train them to the capacity of a promotora or a community health worker. Those terms we would use interchangeably. So we referred to them as peer leaders, and that was very intentional. They were leaders, not community health workers. They were volunteers, not paid employees. And there was a bigger set of them. There was like 30 of them in this effort. And the fidelity to treatment that was required was less, and we got less, right? So in the first one, where there was much more intensity and control by the department, this one, there were volunteers. You can't expect them, you know, to be, you can't have the same expectation if you're not paying people to do this. And so we see that was a little bit different. And then finally, in the California Cord study, we actually went by the term community health worker, because in that case, we were not exclusively reaching a Latino Hispanic population, but we were reaching everybody in the clinic. And so we wanted to make sure the terminology was inclusive enough for everybody. The criteria for selecting the peer leaders, we wanted individuals who had diabetes. They had to be patients of the organization of Clínicas, and they either had to have diabetes or they had to caring for somebody with diabetes. And then for the community health workers, they had to have families. They did not have to have a child with obesity. They just had to be somebody who was interested in promoting healthy lifestyles. And they didn't necessarily have to be the best role models. We actually, for those social psychologists out there, we take much more of the coping model, where we show people that are just leading their regular lives, struggling just as much as you are, and, you know, trying to figure out how we do this, because we want all to be healthy. We just can't figure out how to make it work. I hope that answers your question.
Thank you. The next one is, thank you for a model that takes into account the social dynamics. When you investigated and identified needed changes in the restaurants, for example, the lack of water versus sweet tea, were restaurant employees, managers receptive or resistant? And how did you build positive relationships with them at the beginning?
Yeah, great question. We again only worked in 3 restaurants because we realized after working with three restaurants we had so much more to learn. In general, because I've also worked with small grocery stores, in general, I have found the for-profit food retail industry to be very open to work with me as long as they don't lose customers. So essentially what a restaurant or a grocery store owner will tell me was like, unless I hear people complain, you can do what you want. And, you know, they always engage with the level of fidelity that a science would like in terms of implementation? No. But I'd rather, you know, their employees implement half and do something and maybe sustain it than me being in there and implementing for them, although we do that efficacy work as well. So that has been their response. Do they always maintain? No. And I think more work, as we know, NIH has had a major call for this, more implementation science work, is how do we sustain, or of those innovations that are sustained, what is the impact that they're having? So yeah, not always receptive, but they don't shut the door. I think to some extent, capitalizing on the collectivistic nature of the Latino community has definitely helped us. speaking to for-profit industry and just talking about long-term customers and maintenance of customers. These are families that will live and die in these communities. Not that people don't leave, but you know, for the most part, they're pretty stable. And so these are long-term relationships. So, yeah.
And between the individuals who were retained throughout the entire study and those that had dropped out, were there any difference or trends that,
Yes.
yeah.
Yeah, I would say the one I can remember right now, and it's probably an artifact of how we do research, is that in the California Cord study, so we had the Entre Familia study, it was only Spanish language, right? So we knew this is the dominant need right now. We didn't have enough money to do things bilingual, so we said, let's make it maximally relevant to who we're trying to reach. And then in the Puente study, the diabetes study, that was a little bit more bilingual, although I would say it was dominant Spanish in terms of its delivery. With the California Cord study, we had to make sure that this was relevant to anybody. And so everything had to be both in English and Spanish in terms of the delivery of the interventions. And now I'm forgetting what the question was and I didn't write it down.
If you found any
differences, yes. So what we found, so we recruited a more heterogeneous sample, right? Obviously the first two studies, a bit more homogeneous, Spanish language dominant, you know, a little bit more traditional on the acculturation scales, more likely to be foreign-born. California Cord study, much more diversity because we had to reach both English and Spanish speakers. In that study, we had greater dropout among English speakers. And so it is likely because our interventions had been developed and more in mind, a more traditional, maybe were we too traditional for them? And for some people, if it's traditional, maybe it doesn't really relate to me anymore. I'm more acculturated now or assimilated. I don't know. It's something that we're definitely looking into in future studies. So.
Thank you. And I think we have time for one more question that is going to be a little bit more broad. So your methodology seems broadly applicable to any community for a range of conditions that can be addressed.
I wish, but yes, go ahead.
Is your work being translated this way?
Yeah, well, yes, actually, it's interesting that you say that because since this effort, so one of the things that I've had the privilege is leading now one of the RCMI, Research Center Minority Institutions, funded by the National Institutes of Minority Health and Health Disparities. And in this process have now worked with two different investigators to integrate their research with Clínicas, the organization, the federally qualified health center. So how is it that we could potentially expand some of this work? And one of the nice things was some of the clinical system changes that had been made in childhood obesity were translated over to the treatment of pain. And so there was some clinical system design. Now, have we studied that? No, we need to more directly.
Thank you. And yeah, I want to thank you on behalf of the NIH Academy on Health Disparities and all the NIH. Thank you for such a wonderful talk.
Thank you very much. It was a pleasure being here.